Welcome to the NWAEDC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Lara Strick for the talk today.
So hello again, everybody. I talked to you, I think like 5 or 6 weeks ago about HIV and corrections. And so I expect all of you to be experts now in understanding the difference between jails and prisons. And so I come back to talk on a slightly different topic about taking care of the incarcerated, hospitalized HIV positive patients. And so I presented as a case, a 24-year-old male with a long history of intravenous drug use was arrested 6 months ago. He's brought to the emergency department from jail with fever and shortness of breath for the past month that has gotten progressively worse. On exam, he has thrush, several skin abscesses, and decreased breath sounds bilaterally. And so the first question is can you ask the officer to leave the room when talking to the patients? And I think as medical professionals, we often kind of ignore the fact that these patients come to the hospital with officers and we don't really know what to do with them and what their purpose is and how we should act in front of them. And so basically, patients retain the right for confidentiality in prison and jail, and the transport officers are there to maintain security. They need to have the offender in line of sight at all times in that they don't want them to attack anybody, but they also are there to prevent escape. But they don't necessarily need to be within earshot, and you do have the right to ask the officer to stand in the doorway outside of earshot with the door partially open so that they can visualize the offender. Safety, however, trumps confidentiality. And so if the officer, for some reason, you have some greatly violent offender that the officer feels they cannot leave alone, the officer can be in the room and you're not violating HIPAA by having that officer passively hear information. But I think you should make the point that if and when at all possible, you should have that officer stand outside the room. In prison, when I see patients, officers are actually not present, except if I'm seeing patients in maximum custody. And when it is a particularly confidential issue like HIV, which in prison holds even more stigma than it does in the community, I often will see patients in what's called a no contact room where I can get privacy. The other thing is that, we often learn in medical school that if you're taking a history from an adolescent and mom's in the room, that most of the information you're collecting is not particularly accurate. I would probably say the same holds true taking a history from an offender with an officer in the room. And it doesn't necessarily mean that the information is going to be completely accurate if the officer is out of the room, but at least there's a chance of it being closer to the truth. And the other thing is to just some personal vignettes of how it can impact ongoing care and how in the community you have this huge impact on these guys' ongoing lives. Is I have at least 2 patients. Patient number 1 was a hemophiliac who did not trust authority. He got his HIV from transfusions, and so from his standpoint, we gave him HIV. And he is in prison for over 50 years. And so prison really is his life. He is very paranoid about his diagnosis. And he went to the hospital for a bleed, and he was seeing ENT. And like I think many of us do, he was sent his past medical history, and in the presence of the officers said, I see here you have HIV, which we often don't think anything of. To the patients, HIV had nothing to do with the reason why he was there. And basically, he came back to prison with a new diagnosis. ENT thought he had cancer. And he said, I really don't care. I would rather die of cancer than ever go back out to the community and have my confidentiality broken again. Similar case of a guy who had a septic knee, went to an orthopedist, same story. The only difference was when this guy came back to prison, he basically said, from now on to you, I no longer have HIV and I will deal with it when I get released. I don't want the prison to be involved in my care any further. So what happens in the community really impacts these guys' lives. So medical information should never be given directly to any non-medical correctional staff, if at all possible. They can be given medical information on a need-to-know basis only. And so, for example, they should be given information regarding necessary precautions, what their release plan is, but it shouldn't be direct medical information. Often the officers think HIV status is need to know, but as we all know, because of universal precautions, there really is not a need to know. And if we should all use our gut feeling or personal judgment, and so if you do feel in personal danger, again, that trumps confidentiality, but you can often always stand at an arm's distance and ask the officer to come back in the room when you're going closer to the patient or doing an exam. You do need to also share a plan for the day. You should never, ever make a call on the behalf of the patient because of safety reasons. And they need to know issues regarding discharge or transfer as they are responsible for the offender. So now this patient has a chest x-ray that shows bilateral interstitial infiltrates, which is concerning for PCP. They're placed on appropriate antibiotics and steroids, and they're put in contact isolation for MRSA. They're admitted to a floor team, and that evening the patient becomes increasingly hypoxic, requiring 100% non-rebreather, and is sent to the ICU, and chest x-ray at this point reveals whiteout bilaterally. So now the patient asks, can you call my mother to let her know what is going on? So the answer is you may never, as I just alluded to, ever call friends or family members directly because of public safety hazard. And so we all often learn that you can't tell patients time and dates of appointments. But similarly, you can't make calls on their behalf. And this is often, I get complaints sometimes for the residents in our hospital, because it's probably the most difficult thing for residents to deal with when a patient is dying and they want to call the family and they're basically told they can't from the facility. And the bottom line is that you don't know who you're calling when a patient asks you to call somebody. So the number they give you may be mom, it may be their drug dealer, maybe their mom is their drug dealer. But the point is you don't know, and it's really the correctional facility's responsibility for taking care of safety. And usually they will make every possible effort to get family there if someone's in critical condition or dying. But there are occasions where it is their judgment that that is not safe, and that is still something we need to abide by as practitioners. We talked about never tell patients date and time of their follow-up appointment. As Dr. Harrington can tell you from personal experience, is that patients really
Not as a patient.
Not as a patient, but patients really can plan escapes if they know their date and time and pepper spray the officer and run away. Often hospital systems have a special code word that they use for incarcerated patients, like Mr. Mum word, like mum's the word. But usually you won't know the patient's name until the day of their appointment for safety reasons. It seems obvious, but we are not really used to leaving sharps, making sure they're secured, not leaving anything in the room unattended, and really limiting what you take in the room, regardless, in my personal opinion, of who the patient is. So now back to our patient. Sputum confirms pneumocystis pneumonia. Blood cultures grew MRSA in all 4 bottles. And after 1 week of IV Bactrim, steroids, and Vanco, the patient improves and moves back to the floor. You start antiretroviral therapy with boosted darunavir and Truvada, and you pull the PICC line and switch the patient to oral Bactrim, prednisone, and linezolid in preparation for discharge. So is this a good discharge plan? And the answer is I don't know, because it completely depends on what correctional facility you're sending them back to. So most correctional facilities have formulary and often need to know in advance if you're going to be sending them back, especially if it's an urgent medication like an antibiotic that they can't miss doses. Alternatively, something like I get quite frustrated sometimes because frequently PICC lines are pulled and they're switched to very expensive antibiotics like linezolid, and they come to prison and I actually put back the PICC line and restart them on Vanco. And so I think you really need to know the level of medical care of the correctional facility you're sending them to, because that would be very different to a local jail that often the triage is done by a correctional officer and there's only a mid-level provider there half a day a week, to provide the care. Certainly a PICC line would not be a good option in that case. Opiates are also highly regulated in most correctional facilities, and so you might want to discuss a pain management plan with the facility. But I think the most important thing to take away here is that you really want to talk about the discharge plan with the receiving facility before discharge, not the hour before, but ideally the day before at least. Paperwork that's given to the officer sometimes is delayed getting to a physician, and so if it really is an urgent matter, you want to ask who the correctional medical provider is so that you can call them directly to give report. And truthfully, I think by courtesy alone, it's best to have a stat discharge summary so that the receiving facility knows what went on, because technically it is their patient. So next case, 55-year-old HIV positive male from Monroe Correctional Complex is sent to Harborview Emergency Department with fever and lymphadenopathy. He has HIV for 20 years and his last CD4 cell count was 10. And he mentions that he will be in prison another 10 years and is terrified of dying in prison. And so is it okay to ask the patient why he's incarcerated? And I get asked this a lot. And I think it depends again. You have to ask yourself why you want to know versus need to know. If it's something that you think has direct influence on how you will provide care, then it's appropriate to ask. I think particularly for someone like a psychiatrist, it's often important for them to know. But as a medical provider, I would say it's rarely important to know. And if you're asking only for curiosity's sake, it's usually best not to know, because as much as we would like to think it won't influence our care, certain crimes will definitely bias our opinion towards certain patients and indirectly biases how we take care of them. So on exam, the patient is febrile, tachycardic with diffuse lymphadenopathy. His heart and lung exam are otherwise normal. You have difficulty doing a good abdominal exam because the patient's cuffed in front with a waist chain. And so can you ask the officer to remove the handcuffs and waist chains? And again, I think here we often just assume that however the patient, that we don't even have a right to ask, that it's whatever the patient presents themselves is absolutely necessary. And I think what I want to point, whether it's cuffs or whether it's something else, you always have the right of a medical professional to ask, but not to direct the officer how to do their job. Your job is to say, as a medical professional, this is what I need and this is what I need to do. And it's up to the custody officer to figure out how to make that possible or happen. And so, for example, you would say, I really need to do a good abdominal exam. Is it possible to free up that area? And they would determine how to recuff the patient if that is what is needed. So case continues. The patient's labs and imaging return and you suspect the patient has lymphoma. Oncology recommends an excisional lymph node biopsy, but the patient refuses. You believe the patient understands the risks and benefits of the procedure, and he is agreeable to other less invasive interventions. So does an incarcerated patient have the same rights to refuse care as somebody else in the hospital? And the answer is yes. They have absolutely the same rights to refuse care. They have rights to interpretive services. They have rights to advance directives. Most other civil rights are kept intact. And they must consent to medical care. So unlike what some people believe, when patients are in prison, they have the same right to refuse medications, and we do not force anything down anyone's throat. And the only time we can force medications are actually the same criteria that you use in the hospital, which are if the patient is a danger to self, danger to others, or grave disability. And if the patient is not competent, whether they're in prison or in the hospital, you have to go through the same court system of getting assigned a guardian. Even though they're wards of the state, the facility cannot consent on a patient's behalf. And I will stop there. Any questions?